Welcome, health policy officials, researchers, and public health advocates, to this Executive Explainer. We've got a highly critical, incredibly time-sensitive situation to unpack today. We're looking at the devastating 2026 Bangladesh measles outbreak. It's a severe, rapidly escalating public health emergency, and honestly, understanding the mechanics of this outbreak is absolutely vital for anyone involved in global health policy, crisis response, or epidemiological planning. My goal today is to give you a clear, focused, and data-driven briefing on exactly what's happening on the ground, why the system failed, and what it's going to take to stop it.
Okay, let's dive right into our briefing framework. Today we're going to cover 1. The escalating nationwide emergency. 2. Epicenters and vulnerable populations. 3. The root cause, basically how immunity broke down. 4. The logistical challenges of the emergency campaign. And finally, 5. Reaching the immunity threshold.
Section 1. The escalating nationwide emergency. We're analyzing the unprecedented surge in morbidity and mortality.
To really grasp the gravity of this crisis, we have to look at just how fast it's moving. Starting in mid-March 2026, this thing spread to all 64 districts in literally a matter of weeks. And to put the magnitude into perspective, just look at this number. More than 1,300. That is the number of new suspected measles cases being reported every single day right now. To put that into context, in the entire year of 2025, Bangladesh recorded just 125 cases for the whole year. So we're seeing over 10 times the entire 2025 caseload generated every 24 hours. It's staggering. Building this into our broader epidemiological picture, let's walk through this executive summary data as of May 4, 2026. We're looking at nearly 42,000 suspected cases nationwide, with over 5,500 already laboratory confirmed. Tragically, there are 311 suspected deaths, and 52 of those are already confirmed to be directly measles-related. And you can really see the massive strain on the medical system here. Over 28,800 hospital admissions since mid-March alone. The data is so severe that the World Health Organization has officially bumped the national risk level up to high.
Section 2. Epicenters and vulnerable populations. Let's map out the geographic burden of this outbreak.
So, while the outbreak is technically nationwide, the actual burden is highly localized. The most critical of these zones is the Dhaka Division, which is acting as the absolute epicenter of this crisis. As of early May, the division recorded nearly 19,000 suspected cases and 34 confirmed deaths. But what's really driving the immense hospital strain here isn't just the local population. See, because Dhaka has the most advanced medical facilities, patients experiencing severe complications are traveling from rural areas straight into the capital. And this influx is placing a compounding massive strain on Dhaka's health facilities, pushing them right to the brink.
But Dhaka isn't the only critical zone we need to watch. We absolutely must shift our focus to Cox's Bazar, which is a uniquely high-risk setting. This region houses over 1.2 million Rohingya refugees living in densely populated, incredibly overcrowded camps. In environments like that, an airborne virus like measles, it spreads like wildfire. We've already seen rapid transmission leading to over 330 suspected cases and 3 associated deaths right inside the camps. The existing vulnerabilities of this specific population make the risk of severe complications extraordinarily high.
The really crucial point here is that this outbreak is preying on the most defenseless demographics. UNICEF recently released a statement emphasizing their deep concern, noting that this resurgence highlights critical immunity gaps, particularly among zero-dose and under-vaccinated children. International alarm is definitely growing, because when measles finds large pockets of susceptible, zero-dose kids, it is highly lethal. Which naturally leads us to the most important question of this entire briefing. How exactly did these immunity gaps get so wide in the first place?
Which brings us to Section 3. Root cause, immunity breakdown. Now, what's really interesting about this next part is we're going to diagnose the exact systemic failures behind the crisis.
The foundation for this crisis was actually laid well before the first case was even reported in 2026. Just look at these 2023 figures for routine immunizations. Dose 1 coverage was sitting at 86.1%, and Dose 2 was down at 80.7%. Now that might sound pretty decent in another context, but for measles, the herd immunity threshold is an uncompromising 95%. There's just no wiggle room there. So even before recent events, Bangladesh was operating dangerously below the required threshold, leaving a constantly growing pool of susceptible children.
Tracing the timeline objectively here, following those routine immunity shortfalls in 2023, Bangladesh experienced some pretty significant political upheaval in 2024.
During this transitional period under the previous administration, a severe breakdown in procurement logistics resulted in a nationwide stockout of the measles and rubella vaccine across both 2024 and 2025. Fast forward to March 2026, and the accumulated pool of unvaccinated children had grown so massive that an outbreak explosion was, well, mathematically inevitable.
And we can explicitly link that logistical stockout directly to current patient outcomes. When we look at the confirmed cases today, a staggering 83% of patients are either completely zero-dose or only partially vaccinated. They simply lack the vital, full protection of the two-dose regimen. So the missing vaccines from 2024 and 2025, they are directly represented in the hospital beds of 2026.
Section 4. Emergency Campaign Logistical Challenges. Let's evaluate the ongoing emergency response.
On April 20th, the government launched an emergency vaccination campaign targeting 18 million children under the age of 5. But this brilliantly illustrates the sheer difficulty of emergency public health interventions. The campaign set a highly ambitious, yet absolutely necessary, target coverage of 99.25%. However, the actual administrative coverage achieved during the initial push was only 60.6%. There is just a massive logistical gap between a campaign's goal on paper and the reality of getting shots into arms in the middle of a chaotic crisis.
To actually be effective, policy officials and aid organizations need to know exactly where the system is struggling the most. Several districts are performing dangerously below the average, reaching less than 50% of their targets. Specifically, we're looking at Brahmanbaria at just 37.1%, Manikganj at 38.3%, and Noakhali at 40%. These specific areas urgently, and I mean urgently, require scaled-up community mobilization and targeted interventions from international partners and organizations like the Bangladesh Red Crescent Society.
Section 5. Reaching the immunity threshold. How we mobilize international support to halt the outbreak.
To actually halt this outbreak, the immediate response requires a multi-step approach. Step 1. Authorities have rightly extended the emergency vaccination campaign to May 20th, which allows for aggressive catch-up activities in those low-performing districts we just talked about. Step 2. Immediate scaling of medical care. International mobilization is already well underway. For example, Médecins Sans Frontières has opened a new isolation unit in Cox's Bazar and actually treated 4 times as many measles patients in April as they did in the previous 3 months combined. And Step 3, the ultimate goal. The only way to truly end this is achieving that 95% nationwide coverage.
Let's just remind ourselves exactly why that specific number matters so much. The herd immunity threshold is the precise 95% immunization coverage required to completely stop the transmission of the measles virus. Think of it like a biological firewall. It's what protects the zero-dose populations, the infants who are too young to be vaccinated, and the immunocompromised. Hitting this precise percentage isn't just some arbitrary policy goal. It is biologically non-negotiable for halting the lethal spread of the disease.
As we wrap up this briefing, the 2026 crisis in Bangladesh serves as a really grim reminder of how incredibly fragile immunization gains can actually be. A supply chain failure in 2024 directly led to overflowing pediatric wards in 2026. So I want to leave you with this provocative policy question to consider as you review your own institutional strategies. How can the international community guarantee resilient, insulated funding and procurement structures to ensure that political or administrative transitions never again trigger a deadly vaccine stockout? Thank you so much for joining this explainer. Keep asking the hard questions and keep striving for those solutions.